all the optometry students, I would strongly recommend you should have this book with you. It's like the Bible for binocular vision. And read it how many ever times you want, because nothing can beat that book. Okay, so I think before the break we just spoke about the conceptual framework, and then now I'm going to go to cases with a little bit of, so far we only spoke about managing. We said, okay, let's do assessment, we'll give prescription, and that's the starting point. But you know, BV is about managing, offering, providing vision therapy. But my intention today, guys, is just to keep the whole thing very simple, okay? So you can go back and do something. Not having to invest in like thousands and thousands. So the three approaches to BV is, first is refractive correction. Second thing is added lenses. By added lenses, I refer to any near addition that the subject would require. Near addition, again, I'm talking about presbyopia, multifocals. I'm talking about younger patients with binocular vision problems, like how we are talking about peripheral defocus lenses in myopia right now, where addition is a part of the prescription. We are talking about how to incorporate near addition in binocular vision issues, and of course vision therapy. Okay, so we'll wait for the people to come in as they keep coming in. So this is our next case. 13-year-old student. Okay, so I'm going to of course ask all of you how you're going to manage this case. Blurred vision associated with reading, and this is a very interesting case, and I will never forget this child. So this case is son of an ophthalmologist. Okay, so I told you that do not take your calls based on NPC alone. So it's one such case where he's taken this child to multiple places. He done NPC also for the child. So he was seeing this NPC was 15 centimeters. It was receding and receding. Immediately what we do, convergence insufficiency. Okay, so he was given pencil push-ups, he was given convergence exercises, nothing was working for this child, and that's why the child was brought to us. Okay, and just look at this, what is striking you when you look at the slide? Exactly. If there is convergence insufficiency, there should be exophoria at near. But what is there? Esophoria. Something is first fundamentally wrong there. Okay. Suppose even if you see exo, for this NPC, the exo should be really large. For 15 centimeters NPC, the exo should be something from 6 or above. Okay. If you see a very small exo, again please keep in mind something is going on. Okay. So do not jump into diagnosing convergence insufficiency without doing the combination amplitudes. Do NPA before you diagnose convergence insufficiency, because it's going to take you 1 more minute, right? 10 seconds for right eye, 10 seconds for left eye, 10 seconds for both eyes. If the child takes more time, you want to repeat it, it's going to take 2 minutes. So what does the NPA tell you? Anyone can tell me? Is the NPA normal? No? He's a 13-year-old, right? What is the normal near points of accommodation for a 13-year-old child? Anybody can tell me some numbers, some maths? What is the normal near points for a 13-year-old child? So what is the amplitude for this child? 100 by 20? 5 diopters. The child has 5 diopters. Is 5 diopters okay? Not enough?
Must be more.
Must be more. That much is clear.
10.
That's a frank and fair answer. It must be more. 100% it must be more. But how much is normal?
Approximately 10.
Approximately 10. Okay, you're somewhere close. The second alarm that you see here is the dynamic retinoscopy. MEM value, which is +2. The near retinoscopy, dynamic +2. What's the normal lag you should see when you do your dynamic retinoscopy? Plus 0.75. Okay, that's like the high end. Okay, so yes, what seems to be out of range? Child has normal refraction because refraction is repeated multiple times, nothing abnormal. Phoria, the 2 ESO is within still normal limits, nothing to worry, doesn't seem to be showing convergence insufficiency, 100%. NPC receded, for sure, but NPA is also reduced. All of you agree with me? Yeah? So we just have two values here, NPC and NPA. Now what do we do with this? Immediately, how much is the amplitude of accommodation is the calculation which I asked, and I asked this question. What is the formula? I said a formula before child rate. 15 minus? Exactly. Can you please do the maths and tell me now? 15 minus 0.25 into 13. First 0.25 को 13 से multiply करना है. Then you have to 15 minus. So don't take the 25 out of the bracket and don't make maths too complicated. Okay? Yeah? 11.75. Good mathematics. Great. 11.75 is expected. But how much child has? 5 diopters. So it's like really low. Yeah? So what is the diagnosis? Is it convergence insufficiency?
Accommodation insufficiency.
It's accommodation insufficiency. So how do we make the diagnosis is, if the amplitudes are 2 diopters lesser than the minimum expected, it should be 2 diopters or lesser. You won't call it accommodation insufficiency if it's 11 diopters, it's still normal, okay? It should be 2 diopters lesser. You give 2 diopters as a leverage, then you call it accommodation insufficiency. Now the management is entirely different. For CI, you do CI management. For AI, what do you do? What do you do? Do you prescribe pencil push-ups? No.
We can give prism.
For accommodation insufficiency. What is the number one thing to improve somebody's accommodation? Okay, 35-year-old blurred vision at near. What do you do? No, I can't read. What heart chart also blurred now. I want to read first, man. I can't see.
Plus correction.
Plus lenses.
Plus lenses.
If I can't see, you give plus lenses. First you give lenses, no? So first you give added plus lenses. That's where you start off, okay? This is something I'm telling you that you should not hesitate to do. Don't think about, oh, 13 years only and I'm giving near addition and I'm giving, no. I've prescribed hundreds and hundreds of progressives, done vision therapy, remove them from the progressives, okay? But if you go to start vision therapy with the 5 diopters of amplitude, you will be treating them forever because they still can't see clearly, okay? If they have really borderline amplitudes, you can try vision therapy, I can tell you. But then yes, how do I prescribe? How much I have to prescribe? This is the next question you need to ask. You can't give some random numbers. First is you can do NRA and PRA. We discussed NRA, right? Plus lenses, 0.25 diopter steps. You do PRA, same thing, minus lenses in 0.25 diopter steps. Now see, because the child has really low amplitudes, can't clear minus lenses at all. The moment you put minus, he says like it's really blurred. Take an arithmetic average, which means plus 2.5 minus 0.5 is plus 2, right? Plus 2.5 minus 0.5 is plus 2, divided by 2 is 1 diopter. So take an average of the arithmetic addition, do the addition and take an average, which is 1. This means they need minimum plus 1. It's a number, okay? Another way, look at your MEM retinoscopy, subtract 0.5 to 0.75 from that, and that's a starting point. Do your MEM, subtract 0.5 to 0.75, and that's a starting point. So you can do plus 0.75 to plus 1, and then you start whatever you want after you give this first, okay? You can give this in the form of, generally I do progressives because simple vision for children, reading, removing, seeing blackboard, all of that is really cumbersome. Then you start vision therapy. Now in vision therapy again, remember the sequential approach. I have not put this to complicate things. You can take a photo and keep it and look at it later. But for now, the first important objective for this particular patient is to improve the amplitudes. So whatever you said will work now. You said heart chart. You do your heart chart. You said flippers. You do your flippers. Whatever that you generally do to improve your facility, do all of that after you give the near addition. Okay? Again, no need to memorize. You can just take a screenshot of this and keep it. You can choose 2 procedures from each phase. First phase will go for 4 to 5 sessions. Second phase will go for 4 to 5 sessions. Third phase will go for 4 to 5 sessions. So usually it needs 10 to 15 hours of training for you to then look at, okay, I can now take the child off from the reading classes and then child can go back and live the life normally. You can completely 100% cure accommodative insufficiency. But before that, just remember some of those things I told you. Why insufficiency in this case? History taking, proper history taking. What has caused? Recent viral fever, febrile illness, things like chickenpox, measles, chikungunya. I don't have much evidence for COVID, but then all of these, anemia in young girls, all of these can trigger a lot of insufficiency issues. The most common thing that I've started seeing for over the last decade is a lot of anxiety related issues and mental health issues, okay, causing a lot of accommodation problems. And so please do investigate about it. So then we work with psychologists and therapists for sorting out that problem, because otherwise these things will keep coming back again and again. So yes, but this is the protocol. Of course, there are lots of computer-based vision therapy protocols. This is like a facility training with Binocs, and then this is your monocular loose lens sorting that you do, okay, where you use plus lenses and minus lenses, your accommodative flippers, which you can check outside, and then your hard shot. So these are all some of the procedures that you can incorporate to improve facility. I'm not going to go step by step 1, 2, 3, because you can just open the book, read it, try it on one of your friends, then go start practicing. This is not robotic science, okay? So, but evidence-based management, why am I recommending near addition? Because there are multiple studies that has recommended that minimum amounts of near addition is very beneficial in restoring accommodation amplitudes, and it creates reserves for the child then to have better compliance with therapy. If you put the child directly on therapy without giving the addition, you will be treating the child forever. But if you improve the near addition, improve the amplitudes, then immediately your therapy will work like that. Then you take away the addition. So these are all studies where you can look at flippers versus addition. Comparison they did, and they found that accommodation is, near addition is better. Again, sham treatment, which is placebo treatment, they did comparing. So there are lots of evidences that talk about how much to prescribe, okay, +1 or +2. Again, it's all, look at it, mean age is 11.8 years, okay. So there are multiple studies that talks about prescribing near addition and accommodative insufficiency in children. So use your MEM as a starting point, subtract +0.5 to +0.75, put the addition, recheck the NPA, start your vision therapy. And then if you recheck the NPC, tell me, we saw that the NPC was 15 centimeters in this child. What will happen after you prescribe addition to NPC? Let me see how your logic works. So NPC was 15, we've given addition now. Logic says after I give addition, NPC worsens, no? Nobody asked me that question. So what's going to happen to this child's near points of convergence?
It will worsen.
That's what we believe in, but what will happen in this case? What will happen in this case? Why is this NPC with accommodative target 15 centimeters here? If it's not because of convergence issue, it's because of the poor accommodation. Because accommodation is not acting, convergence is also not acting. This is pseudo-convergence insufficiency. So after you prescribe your addition, if NPAs improve, NPC should also improve in this case. That's it. It will not worsen. In true convergence insufficiencies, it will worsen. And that's how you distinguish between pseudo-convergence and true convergence. You understand? So then, don't jump into, so 2 messages. Don't jump into diagnosing CI without doing NPAs. Do NPC and NPA and then make your diagnosis. Second, don't just run into vision therapy just like that without ad hoc, without really prescribing some small amounts of addition to enhance the amplitudes. Clear? Any doubts at this point?
But one thing I have to add.
Please.
You see, if this is done in a hospital, it's fine. But if it is done in a private clinic, an optometrist does it, the parents are scandalized. They'll say, oh, bifocal prescribe kar diya mere bacche ko. They run and find out. Then they go to 4 ophthalmologists, spend all the money, and 2 of them tell this is all rubbish. We have been given. So you see, this is going to fail, and I'm practicing for 40 years.
Right.
And when you give it, hardly 2 or 3 parents are smart enough to accept what we have diagnosed. So theoretically, it's beautiful. But, and I'm sure you have done it quite a lot, but the acceptance of bifocal or progressive glasses to youngsters, because the concept is bifocal or progressive are for older people.
100% I take your point.
It is, there's a lot of and if you don't handle this properly, it might destroy your practice reputation, because if two ophthalmologists agree with the parent's perception of the child is suffering, all right.
Right.
And bifocals obviously cannot be given because of cosmetic issues, so it will be a progressive.
So I'm more doing from bifocals, do multifocals.
Multifocals.
Yeah. The way I handle this is like, I totally agree. I see the challenges. One thing I do is, okay, I of course talk to the parent, as this is like odd, this is not the usual practice, and then this is temporary. Like we're going to do vision therapy and take the child off the glasses. Number two. Number three, if they are already consulting with an ophthalmologist, I write a referral letter to the ophthalmologist saying these are my findings and this is how I'm managing, and please use this and consult with your ophthalmologist, and they can reach out to me for any queries, any questions. And if I'm able to pick up the phone and talk directly to their eye care provider, I do that as well. Now these are all some certain things that would increase the trust immediately in the parent right at the moment. And then also would, because now they're going to anyway come to you for 10 to 15 sessions of vision therapy as well. You have to ensure that happens. But despite all of these, I know there are patients that are skeptic about these things, but this was pretty easy, but I've done many, so yeah. Okay, so moving again to the next case. Let's see, this is easy to crack, I guess. You see the symptoms, eye strain. Again, nothing much with visual acuity and refraction. So I'm just going to keep quiet and ask you for diagnosis now. Let's see how many of you start shouting. This is the most commonest case that you would get to see, as I said, like the beginning of the talk, I said 16% of children have this anomaly. And what is this anomaly? Convergence? Insufficiency. You can be very clear about it. Because you have two major numbers sitting there. Near exophoria, receded near points of convergence. Correct? And NPI is normal. 12.5 diopters. Of course, for the 10-year-old, if you do your calculation, it will be 15 minus 0.25 into age, which is 12.5 diopters. So the child, of course, has really good normal amplitudes. Now, near exophoria and receded NPC. Near exophoria and receded NPC are diagnostic signs of convergence insufficiency. Okay? Now there is nothing. Now you just have to manage. Now I'm going to ask you the question. What is your preferred treatment for this patient? What's your preferred treatment? I just talked to Pradeep Sharma.
Pencil.
Because I was expecting him to be there and...
Pencil push-ups.
Pencil push-ups, okay. I am not a anti-pencil push-up person.
Brock string.
Whatever works, please do.
Brock string.
Brock string, okay. Lifesaver cards, okay. Something you do, but objective is to improve convergence. Correct? Okay. So that's why I said Dr. Pradeep Sharma I miss, because I use him, I call him every presentation. So he did this literally in 2008. Okay. So he did the study on preferred clinical practice in convergence insufficiency in India, a survey. And as you see, pencil push-up was the most common first line of treatment offered by ophthalmologists, 79%. And then there was a repeat study recently from some other parts of the world, and things haven't changed much. Okay, so a lot of people still prefer pencil push-ups because of the simplicity of the treatment, and it has worked. Otherwise, why would people give? It's worked for people. But the question is, there are multiple components of vergence as we discussed. There's dynamics, there's amplitude, there's facility, there's step vergence, there is smooth vergence. Vergence is not just one straightforward number like how you see in NPC. So this landmark study by the CITT study group, the Convergence Insufficiency Treatment Trial Group, you please go Google this. They've given study protocols, okay, SOPs for the study, where all the procedures from how to do NPC, NPA, how to do heart chart, everything is written and uploaded on their website, on the NIH trial website. The whole trial itself is a textbook. Okay, you can just go download and start running a vision therapy clinic as such. It's such an important landmark study and a trial. So in this study, my mentor, Dr. Mitchell Scheinman, of course, multiple papers came out of the study, and they compared vision therapy with pencil push-ups, with placebo, different age groups, and finally this study checked different components of vergence also, okay? And they had a placebo group also, like they didn't do anything. It's a part of the PD guide group, okay? The PD study group, which we are familiar for amblyopia. and of course then they came up with this protocol. So this is again another phase that we then adopted for all our vision therapy patients. If you see phase 1, you train gross convergence. In phase 2, you train ramp. Ramp is speed, okay? In phase 3, you train jump, which is facility. So you don't just go and do 100 exercises to the patient on day 1. Please don't do it. Take them step by step. If you want to do 3 sessions with just Brock string, barrel cord, lifesaver cord, do it. After they are very comfortable, the next 3 sessions, introduce eccentric circles, your computer orthoptics, whatever you are using. Because if you introduce eccentric circles at the beginning or lifesavers at the beginning, they'll run away, especially when they have a very severe convergence insufficiency. You should know how to sequence your protocol, okay? So Brock string is a good place to start, barrel cord is a good place to start. Then on the 3rd phase, you start introducing loose prism jumps and binocular procedures. Everything is binocular, okay? And this could be 3-3-3 sessions, this could be 4-4-4 sessions. But 12 to 15 sessions, good number. I'm like a big fan of 10 sessions, and I've done 10 sessions consecutively or alternate days, 45 minutes per session. So for this particular patient, we did, as you see here, lifesaver eccentric circle cards, lifesaver cards smaller. As you see, we did that, and then we did barrel cards, and then we also introduced computer orthoptics using random dot stereograms. And after 10 sessions, what is most important for you is invariably document this. Don't just run away from documentation. Document the status, the near cover test, the NPC values, the fusional vergence ranges, vergence. If you're doing like full battery of BB, then you have all of this. But at least cover test, NPC, fusional vergence ranges and binocular facility are like a good place to start, okay? So we did pre-vision therapy and post-vision therapy, and then phenomenal improvement. This is just one case, there are multiple such cases. The CITD study, of course, have done hundreds and hundreds of patients where vision therapy for convergence insufficiency is very efficient in not just improving the signs, but in improving the symptoms, in improving the sustainability of the improvement also. Like you don't train and then they go back and things come back, right? So after 10-15 sessions, people ask, do they not develop CI again at all? If you've really like worked on the vergence ranges, it's a very sustainable attempt, okay? So look at using scientific evidence. Any questions at this point? Any of you would want to manage this patient differently, want to prescribe prisms for this patient, want to say anything else? Any other views for this patient for CI?
We can give prisms actually.
You want to give prisms? Okay, how much would you give?
2 prisms basic.
And then what should you do after that? What are the pros and cons of prescribing prisms? Okay, let's say 12 exo, you want to give 2 and 2, so that's like 4. You decrease the exo from 12 to 8.
Plus vision therapy, so convergence will improve gradually.
Okay, so you want to put prisms and then start therapy.
Correct.
Okay, that's your approach. Anybody else wants to try anything else? Who would use prisms first? Raise hands. Okay, I mean nothing wrong, of course. I'm like a big fan of prisms. What happened? Wake up. Yeah. Who can give prisms? Like I'm not against prisms. Who wants to give prisms for this patient? Okay. When do you give prisms? When do you generally touch prisms?
Easy.
Look at this case. It's just nice segue into prisms. When patient has double vision, okay? So when they say like I'm really seeing intermittent double or manifest double vision, like they start seeing double. Prisms are really like you don't know like how in accommodative insufficiency we said don't start vision therapy, give plus lenses, then do therapy. Same way when they have double vision, do prisms, then start therapy. Okay, so I'll give you indications for prisms through this case. This was a 17-year-old male that came to us. Again, nothing significant with respect to refraction, but look at this. NPC was really receded. The exo at near was 16 prisms, okay? Now, one of the major, I'm going to go a little bit deeper into maths now. How do I know that this patient will benefit from prisms? Is the question we need to ask. We do Fourier at near, and then we also do vergence amplitudes. For those of you who haven't started BV, I know this is a bit too much. So leave it, allow it to go above the head. But those of you who are already into BV, please listen to me. When you are looking at near values for foria, so exo, right? 16 exo, the eyes are really out there. Now you want to know what is the convergence amplitudes of this patient, okay, which is the compensating vergence. Now how all our eyes are looking straight, of course, I mean I do have a large exo, but then most often I don't dissociate. How is the eyes are maintained in alignment? Because of the fusional vergence. The eyes are kept aligned by our convergence mechanism when we have an exophoria, right? So you want to find out what is the maximum ability of this person to converge, okay? So you put base out prisms and you measure what is the maximum amplitude or the available fusional reserves for this particular patient. So when you put base out prisms, with 12 prisms this patient was just breaking, is it double? So 12 is the maximum, the amplitude for this particular patient, 12 base out. Now use your maths. If someone has got 16 exo, they must have at least 32 prism diopters of fusional vergence amplitudes. Double. The fusional vergence amplitude should be double that of the foria. If it is double, usually they don't have symptoms. Usually they are good. They don't have double vision. Okay. But when it is lesser than that is when they start seeing double, because the fusional vergence reserves are not adequate to keep the eye straight, and that's when you start seeing exo. Now this is also very risky because this patient can even develop intermittent divergent squint because the fusional vergence amplitudes are really low. So this is what is the criterion that we use, where we look at the relationship between the demand and the reserve. The fusional reserve should at least be twice that of the demand, which means if you're talking about exo, the positive fusional vergence should be twice. If you're talking about ESO, the base in value should be twice. Okay? If you're having exo, base out value should be twice. If you're doing ESO, the base in value should be twice. If it is not, you calculate prism. Now, without even doing this formula, what I do is 1/3 of the foria. So foria is 60, 1/3 of the foria is how much? 1/3 is not 4, man. Close to 4?
5.3.
Whatever. So you split between both the eyes. Okay? You equally split between both the eyes. If you want to really go very ophthalmic way, use this formula because Shear did lot of work and came up with this formula. 2/3 into 16 minus 1/3 into compensating vergence, which is the 12 number that you see here. You plug it here and you calculate and you will get 6. Okay, so use this formula to find out what is the minimum amount of prisms that you should be prescribing in such patients where the fusional vergence is not twice that of the foria. Understand? So then you split it between both the eyes. Now coming to this question that I asked you, when do you prescribe prisms? In younger patients, my first choice is always vision therapy. Okay, because in 10-15 sessions I'm done, they go home happy. Because when I put prisms, the number one risk I'm taking is the dependence on prisms. Again, there is not much of a research, I would be very frank, because many practitioners are actually even very successful with prisms also, they talk to me. But then there are studies, there are patients that I've seen in my practice where they're just being given prisms sometime and they just don't want to get rid of the prisms. They just want to be with the prisms all the time. And I've also seen cases where we call eating up of prisms. We see the number of prisms increase as they just keep wearing it. So today they need 6, tomorrow they will need 8, 3 months later then it would be 10, and you know the glasses thickness also then keeps increasing. But when we do vision therapy, the dependence on the prism part is taken care. And we also look at a more sustainable treatment option, right? We don't want someone to be on a myopia control option until lifetime. We want to do it and then get rid of it, wean them off so that they are able to be without any or standard treatment protocol. Then if there's diplopia and if you start vision therapy and they just can't do it, they're like everything is like difficult for me, I'm having intense headaches and eye strain, then you know like they need prisms, okay? If they're presbyopes, ask me, I love prisms. I just start with small amounts of prisms and then start vision therapy because they're really helpful. And of course I do what's called associated foria, which I'm not going to cover today. It's very similar to the Bernal imbalance measure, but then we use polarizing glasses. If you're already having phoropter and digital chart, you do have associated phoria. Well, binocularly you measure the minimum amount of phoria and you prescribe prisms. But this is my protocol, again an evidence-based protocol. So coming back once again to the place where we started, the management sequence for BV is to first provide appropriate refractive correction, look at near addition lenses, then add vision therapy. So for this particular patient, after prescribing prisms, once again go back to the CITT study protocol. Phase 1, 2, 3, do therapy, then look at if you can wean them off with prisms. And now vision therapy options have become innovative, feasible, remote monitoring is possible. As I told, even online consultation for assessment has become a norm right now. There are multiple providers available. So we did also look at the diagnostic accuracy of these softwares in a paper that I published, where this is one software that I personally developed, and it's being used in a tertiary eye care center in India. But I'm like a lover of all of the training kits. So we also, in the book, we tell you what is the training kit that you want to have to start your vision therapy practice. You don't really need to have these tools. But yes, softwares have made life much easier. Something that I always like about objective measures is that the numbers are there, right? So parents get to see, oh, the number is today this much and tomorrow it changes to this much. And then objectively, it's very easy for us to also monitor the improvement. And when you do your CAT card or your lifesaver, child say single, you don't even know if they're really seeing single. But with the help of these softwares, then you really know that it's working, it's not working, there is a feedback loop. So all of this then makes it really easy. And I know some of you find all of this to be really very overwhelming at this point. So I'm going to pause and then take a poll at this moment before I continue with the myopia session, which is the next session, where BV, myopia, prescribing and all of that. Okay? So this is a pick by my mentor. So go back to take your mobile phones, start typing in whatever you learned thus far, and then we continue. I'll open the website so that you can directly then... Yes, ma'am, please.
For those who joined late, probably they will have to get registered through this app. The barcode is here.
Yeah, so look at this. Just scan the barcode, menti.com, or use the code. But somebody typed something and it has gone behind the QR code. Huh? It's okay, it will come now. Just as more and more people start typing, I think it will come. Scan the QR code, whatever you learned up until now, whatever just immediately pops up in your head, okay? Just put that. If you want to share more than one, please do share it.
Rizwan, I have a question.
Yes, Sumay.
I just want to bring one case.
Yeah?
I'll give you the mic.
Yes. Okay, you guys can keep continuing, right? Yeah.
Keep typing.
Okay, the topic was fabulous over the head.
Thank you. Thank you.
Sorry for that. But I came across some interesting cases where adult 30-year-old, I'm just dropping the case, you can give me your how to handle this case. And this gentleman has 6/6 vision in both eyes, and he has a diplopia, uncrossed, and now the doctor doesn't know how to handle it. Squint surgery done, I think it was 30 PD, corrected, it is aligned, ortho,
Squint surgery done for what deviation?
exo, 30 PD
Now
exo.
he has contributed to ESO.
It
Become a little ESO now.
Unfortunately, follow-up assessments were not done in terms of deviation, but it looks ortho, but the patient complains diplopia, one beside the other, which is uncrossed diplopia. That's the complaint. That's all I have. 30-year-old.
Yeah, thank you. In fact, Sumant, not that everything, the purpose here is, of course, we know. So what we actually wanted to tell the audience, some are there, but some are beginners. There's so much in binocular vision. Sometimes the terminologies are also not known. At least when we've known these terminologies, we'll go over and bring them level to that edge. Thank you so much, Rizwana. Any guesses on what this case could be?
I know the answer, so. the person has got anomalous retinal correspondence, Sumant. So, So you were testing me seriously?
I was trying to see if somebody would pop up and say, yeah.
Yeah, no. So he's a typical anomalous correspondence and looking at the age and probably operated at a later stage. But usually anomalous correspondence is there in IDS or intermittent XTs, but more common in ESOs where they get operated, and that's when we evaluate for ARCs, anomalous correspondence before surgery, do prism adaptation, ensure that what's the amount that needs to be then operated for safer thresholds and all of it. But because you say eyes are ortho but then uncrossed, so it could be paradoxical anomalous correspondence then. So yeah, we need more evaluations, try prisms. One way I can handle such patients is neutralizing wouldn't work, so I put prisms in the opposite direction and then push the image away from the field or something like that, or central patching using Bangladesh foils or whatever. But unfortunately, sometimes these intractable diplopias are pretty difficult to manage. Having said that, especially smaller amounts, we could try vision therapy just to see what's worth it. Provided in 1 or 2 sessions, I'll keep a close watch to see whether it's increasing, decreasing, then stop, take a call. But yeah, anomalous correspondence is where this all starts and ends with, yeah.
So let's assume that I'm keeping this case as simple as possible.
As you keep speaking, 1 second. This is so fantastic. Now look at this. Case reviews, sequential management, new insights, CIAI. Brilliant, guys. I'm happy.
Can I?
Yes.
Yeah. So I'm trying to keep the simple cases as simple as possible. Reason is, if I am practicing, I'm an optometrist also, but if I'm practicing, I don't. I'm not this BV guy. So I want a simple strategy to handle a case. What do you suggest? First line of management to start with. I don't know how to give prisms. How do I handle it?
Yeah, so the home therapy kit which we've suggested as part of the whole manual is the good place to start. Yes. And then the phase 1, phase 2, phase 3, pick one from each and start. Okay?
Ma'am, quick addition.
Yes, please.
As this case, interesting case, right?
Yeah.
So first of all, doctors or squint surgeons tends to do overcorrection for any kind of XTs, and that is a known thing to happen. At least 15 diopter of overcorrection is very common. If it is immediate post-op double vision, I would say it is due to the overcorrection, as you say that it is a consecutive esotropia,
Right.
Which is post-surgical.
Yeah.
That is common. So over a period of time, it may go off. Now, as a beginner, as a practitioner, what we need to do to check at what point diplopia is going off. Whether any kind of prism it is accepting, which is based out in nature, then it is okay. I'm not worried about. But if it is not accepting, that means the ARC comes into place or AC comes into place, and that is where the tricky things comes as a high level of treatment. And as you rightly said, then you go for either suppressing the image, central scotoma producing that,
Yeah.
or what we do is probably you
Reverse
go
prisms,
beyond,
yeah.
reverse prism to go beyond that fusion.
Inverse prism.
Inverse prism.
Yeah.
Thank you.
Thanks, Oli. Agree. So just to keep things in perspective for whatever that's gone inside the mind, and you've given me some feedback, all of us. So during the break, we did announce that if any of you want to procure a copy of this book, please reach out to the team LDV. And I'm going to move into the myopia session now. Okay. So any other questions, guys?
I have a question at the vet.
Yes, ma'am, please.
Me and optometry are friends for a long time. I'm
Uh-huh.
a primary and glaucoma specialist. But yeah, if the ARC is established and entrenched at the age of 30 and the patient has diplopia, you do take a consent before surgery as a surgeon. How long does the diplopia in your experience keep on happening? Because we are old time, but we were told the patient adapts to it over some time, right? Dr. Pradeep Sharma was my teacher too. So it adapts over some time. Is that true now?
So again, it depends on the direction of the deviation. XTs are pretty easy to manage, but ESOs are not. And that's when the prism adaptation test that we do before the surgery will actually tell us where are we with respect to getting them really straight with the least of complications. Suppose let's say you have 30 prisms of esotropia, okay? and then you do your prism adaptation and the patient starts seeing double right from 15 prisms onwards. Now you have a larger difference between the subjective and the objective angle, and you need to either undercorrect in that case. I mean, you definitely can't overcorrect usually. So this is once again the talk that we need to have with the patient, the cosmetic alignment versus.
Why would they go for undercorrection? They come to you for cosmesis,
Right.
like to convince, like he said, to convince a patient and the parents or whatever the case, because it's very difficult. And the other is that just a small laughable matter. Don't make it BV, make it bye, because BV means you have a BV.
Other way I manage the case is that, let's say if they have 15 of subjective angle, prism adaptation, slow and steady, we increase it. We get them closer to 30. So the pre-surgery time period, we prolong it. Like, for 2 months, 3 months, 2, 20, 25, we break the ARC. So all the therapy happens before the surgery. Break the ARC, get them closer to the objective, then send them for a more successful outcome. That's how the current management protocols. Okay guys, so now I think, I'm sorry this has gone out.
Yeah, we have, of course, Vidisha, quick one, we'll take it. And certainly we have, interestingly, myopia control and binocular vision.
I'll just, no, that one slide alone is, I keep it like this, so. Yeah. Yes, Vidisha.
I would like to just put a light over here that ma'am was asking before the surgery. What test can be done to rule out specifically patient has any ARC or not? Because patient can have a long-standing suppression as well. The patient maybe can have a congenital squint around 55 to 60 diopter around. And suddenly the patient has come around 30 years and we operated and suddenly it's come as an ARC.
Right.
So prism adaptation test is very much mandatory before prescribing or prefer going for the surgery. So this is very much important. So what we can do, as soon as the patient will be coming in our pediatric or screen clinic, we can put the prism diopter and maybe we just put the prism based on the ESO and EXO, like base out and base in, and we can tell the patient, ma'am, is it possible to see double vision? If it is single, then we have to put the red filter. To find it out, is it suppression or it is or something else? So most of the patient long-standing squint is very much important to rule out exactly is ARC is there or long-standing suppression, or probably we can go for surgery. So for those patients, I think we should refer to the orthoptist clinic to rule out the suppression or ARC, then go for the management for squint, and after that maybe immediately after the surgery, patient can have double vision. We think and wait for 2 to 3 weeks probably. If it is very much tolerable for them, we can give for patching therapy. After that also, if it is not eliminated, then we have to evaluate, then we have to go for prism and vision therapy.
Thanks, Vidisha. I would love a 46-hour workshop on this topic. So.
I know each case is so unique, in fact. Thank you so much.
Yeah.
We'll run to the next.
Yeah, and then for my ARC, what instrument I love the most, synaptophore. Okay, so that's something that once I thought I was learning and studying and I became a bit arrogant. I'm not going to use synaptophore, but the moment this whole ARC thing came, we tried different techniques, but nothing worked like the lion in the cage. So I love the synaptophore. Okay, coming to myopia management, of course, I'm going to touch a little bit evidence here, because a lot of us are getting into myopia management now. We are like, oh, I'm going to do my defocus lenses, I'm going to do my orthokeratology and this and that, and then you put you give the management, they come back with some problems and we just don't know what's going on. Is it my dispensing? Is it my advanced specialty lenses not working? What's happening, right? So I'm going to talk about the known and yet to be understood. When it comes to BV, we used to believe that BV is a risk factor for myopia progression, but I'll have to agree that there is not much evidence to say that BV actually causes myopia progression. No, it is just an association. Okay, and so that's the place where I want to start. And this is especially something, even if it goes above the head, I would still want to make my point here. This is what I call as the Wick's conceptual model of hematropization. Take a photo, keep it, go look at it. But in optometry school, of course, in your pediatric optometry, you should have learned this. Now, this is a model that Professor Wick introduced in 2000. And in myopia, we all know about this acceleration in the axial length, the growth that happens with the axial length because of scleral tension and this and that. And that's what we call as the visual growth. Okay? So, as the child, the eyeball grows, genetically programmed the ocular growth happens, right? But Is the axial length elongation only because of genetically driven growth? No. There is a lot of input from the accommodation and the version system which we call as non-visual growth. Because constantly there is a feedback loop that goes from both the eyes, from the binocular vision system. That's where your peripheral retinal hyperopic defocus comes. That's where your lag of accommodation comes. So any amount of blur with respect to the lag or the peripheral defocus is going to add to this genetically programmed ocular growth in some way, and definitely it's going to impact the influence. It's going to influence the axial growth. Okay, it's going to add a little bit to zonal tension. It's going to impede with the way the lens grows. Because in hematopization, the axial grows, the lens thickness gets altered, the corneal curvature changes. But all of this is also impacted by non-visual growth. So it's never just a genetically driven growth, but it's also there is influence of peripheral hyperopic blur and lag of accommodation. So in myopia management, what you need to know is mainly if you're handling a child who's at risk for myopia, both parents myopic, child is not yet myopic. Okay? That child comes to you. What do you look at? What are your BV parameters? Now, we said BV anomalies, highly prevalent. So all your myopic children are most likely to have some BV anomalies. So you have to still handle them, not only handle myopia control, but also handle the BV anomalies in that. Then you do myopia control option, you do your defocus, you do your orthokeratology, you do anything, okay, DIMS, myosmart, myocare, whatever you want to do, you do your low dose atropine, anything for that matter, you should definitely ensure you do your BV before, after, to see how the myopia control option is interacting with BV. Then, of course, put all of this together, okay? So I'm going to once again start with cases. I'm going to just show you this and ask you what test you would do. Now, we've already spoken about the minimum battery, all of that, okay? So look at this 13-year-old child wearing a -4 prescription. I've given you cycloplegic refraction, okay? If I want you to do BV, what test you will do? Please give me your answers. Intermittent blurred vision, okay, a cover test, okay? MEM retinoscopy, great. I think 2 major tests got up. NRA, PRA. Okay, let's keep it the minimum. If I give you only 5 minutes to do BV, then NPs. So he said 4-year and you said MEM. Anything else? Because already you've done enough, like you've done biometry. Okay, you put them through all the myopia assessment. Now you have to add a little bit BV to it. NPA, okay. Anything else, guys? To manage this case. Of course, nothing seems to be wrong as such. Looks like prescription has increased. Half a diopter change over 6 months. Myopia progression has happened. You might want to introduce myopia control option. But before that, if I want you to do BV, what would you do? Okay, so we've got some answers. Okay, next, myopic adult, software professional, but has intermittent blurring with the prescription, no change in refraction. What BV test would you do in this case? MEM again, okay. Anything else? Accommodative amplitudes and facility, okay. So I don't know why a lot of silence is there. Are you hungry yet? I don't think so. The impact myopia management guidelines. Of course, most of you would have gone through this, a beautiful paper that talks about what are the steps in myopia management? Identifying the myope, mapping the risk factors, picking a progressive myope, advising myopia control strategy, counseling, finally tapering and cessation of the myopia control. Now this is the impact protocol. Now where does BV come in? It comes in M. Okay, as part of mapping the risk factors, binocular vision is an important component. You can't ignore binocular vision. So in the myopia workup, you do risk factor profiling, you do ocular biometry, and you also do BV. Okay, you don't keep BV out of your myopia management. Now some of the important things that already exist, research has shown that in high myopia, there is a likelihood of near esophoria going hand in hand. Okay, so because, or other ways to put it in other words, when someone is progressing, they are more likely to shift towards ESO. Okay, so whenever you see ESO in a myope, put one red flag. Just put one red flag. That's all you need to do. Oh, the moment you see a ESO in a myope, especially when the myope is progressing, there is something happening. The ESO then tells you that there is a risk of progression. Okay? And it both go hand in hand, but we never know which came first, is it the myopia or the ESO. Now why am I telling you ESO again and again is because if you look at all of the normative data papers, the band study, so this is where recently a published paper where the band study is also here, talks about the foria values. So if you really see here in children 11 to 17 years, the ranges are always exo, okay, or 1 ESO to 4 exo, ortho to 4 exo, ortho to 6 exo. So ESO in any child is actually abnormal, okay. So 1 to 2 ESO you can take it, but otherwise across ethnicities, be it Ghana, South Africa, Portugal, United States or India, the ESO as such is really very less, the prevalence of ESO. Then this is a study from a large data set in 18 to 30. Shenbagan, you asked about adults. Once again, the shift of, if you really see, a large percentage have exo only, even in the adults. The amount of ESO that you see in adults is also very less. So because if you all go back to the basics of binocular vision, we all have very good fusional convergence amplitudes, and then our eyes are more or less likely to be aligned. And when it comes to ESO, we do not have enough of divergence amplitudes. So it's really difficult for us to manage any amount of ESO, okay. So even a small amount of ESO, most likely they tend to have symptoms. And anatomical position of the eyes is also naturally divergent. It's not convergent. So normally our eyes tend to be more divergent. So you will see exo, physiological. That's why we call physiological exophoria. We don't say physiological esophoria. Okay. So any ESO you see in myopes, please put a red flag. And again, I'm just showing these slides again and again, which is also there in your handout. And this prevalence data is something you need to remember. Now this should tell you that myopia and the BV anomaly can coexist. Okay. So if you see 10 myopes, 3 out of them can have a binocular vision problem. It's not that the BV is causing myopia progression, or because of myopia progression they have BV. They have a BV anomaly, they also have myopia. That's all. Now you manage myopia, you also manage binocular vision problem. You don't ignore this. You don't ignore BV because they are myope, and then all your focus is on providing myopia control option. Now coming to myopia control strategy, this is a beautiful study by Kate. Of course, Kate has done a lot of work as part of the myopia profile. If you go, there are tons and tons of information, education available. There's a free course also on binocular vision assessment in myopia, okay? And this is part of a doctoral research where she investigated binocular visual function in young adult orthokeratology wearers versus soft contact lens. And if you see, young adult myopes wearing orthokeratology display more exo and lower lags compared to single vision contact lens wearers. I will make this simple for once again all of you here. Multifocal soft lenses, okay, or orthokeratology definitely interacts with BV. Please understand that. I mean, there's no way that they're going to be, BV will be altered when you are prescribing a peripheral defocus or multifocal soft contact lens or orthokeratology. Let's first stick with contact lenses, okay. Whenever you're prescribing contact lenses, you know who benefits from contact lenses? Someone who has esophoria. Because as you see here, when a person has exo and we are going to prescribe them with contact lenses, it's going to increase the exo, right? Because spectacles have base-in prism effect, so they are more beneficial when you see a myope with exo. So when you see a myope with exophoria, think about spectacles as myopia control options. When you see a myope and you see an ESO, those are the ones that would benefit from your ortho-K and your multifocal contact lenses. This is simple logic. There are multiple papers, there is this flow chart, but when there is no normal phoria, you can choose anything. You can choose orthokeratology or multifocal. But beware of prescribing contact lenses whenever there is ESO. There's one line, if there's one line moral of the story, when there is a esophoria, please beware before you prescribe contact lenses, because contact lenses can increase the ESO. Sorry, can increase the exo. I became like super confused now. Yeah. So if there's an exo, beware of prescribing multifocal lenses or orthokeratology because they can increase the exo, but they can be beneficial in esophoria. Okay? So this is something I wanted to tell you about myopia control as such. But once again, the minimum test battery remains the same. Again and again, I will tell you, do your folia, do your near points. In myopia, I would add accommodation response also. So this is your facility. Of course, the videos I will play during the break. And I think Dr. Digvijay is not there. He asked about open field autorefraction in the morning. So you see here, this is an open field autorefractor. I'm not sure how many of you have used it, but it's becoming more and more relevant in myopia control now, because the closed field autorefractors, as you know, because the target is located inside and it can, the proximal accommodation instrument myopia sort of comes into picture. It overestimates myopia, but open field autorefraction, as you see here, okay, has an open view, so the target can be outside. And this is, we've done a lot of research once again, and we've also shown that it can be used in school eye health programs in the place of cycloplegic refraction, okay, open field autorefractors. And you can use open field autorefractors to measure dynamic, do your dynamic retinoscopy, but you can get continuous accommodative measurements also, okay. So open field autorefractor is again another interesting tool that you can start to explore. As you see here, it gives you the refraction, it gives you the near lag, it gives you the pupil diameter, it gives you continuous accommodation measurements that you can save as an Excel sheet. It's like a fantastic tool when you want to do your research, okay. Of course, the famous dynamic retinoscopy, and this is your muscle imbalance measure card, okay, the folia measurement. So as you see here, the card is kept closer, the Maddox rod is put, and then the folia measurements are done, okay. So going back to this particular child that had 8 prisms of near ESO, 13-year-old that progressed, what we did is we did 4 procedures. All of you were right. We did the folia, we did the near point of accommodation, we did accommodative facility, and we did MEM retinoscopy. So because we were talking about what PV test to do in your myopes, right? So these are the 4 procedures that we did for this particular patient. I know for some of you already it's really becoming a bit heavy, but now this is where I want you to now tell me, how would you manage this case? There's near ESO, there's a large lag. From whatever that we learned thus far, what would be your myopia control strategy for this child? Okay, you give flippers, okay. So the child has progressed from -4 to 4.5, and then there is this ESO also going. Will you prescribe a single vision spectacle, or would you go for something else? Optical correction wise. Progressive lenses.
Low
okay.
addition. Low addition.
Low addition. Okay, or a defocus that comes with the low addition incorporated multiple segments. But yes, you cannot give single vision lenses in this case. That's the most important message. If you really see, even if you prescribe +1 addition, the 8 ESO will go, because AC by A ratio is 8/1. So prescribing +1 will reduce the ESO by 8% diopters, which means you can achieve orthophoria by prescribing +1. That's what the AC by A is telling you here, okay? So again, this flowchart, take a photo and keep. If the accommodative lag is anywhere from +1.25 to +1.5, and if the accommodative facility is poor, difficulty with minus lenses, the person needs near addition, okay? So once again, if somebody has normal lag, facility normal, you can just prescribe single vision, or you can prescribe your low dose, whatever, you can follow it up. But if there is a combination of larger lag, difficulty with minus lenses, which means difficulty stimulating accommodation, and a near ESO, the person needs low addition. Okay, the person needs addition. That's very important. Again, esophoria, any esophoria above high or 3 to 5, start considering addition. Any ESO more than 3% diopters, start considering addition in myopes. Okay, so we prescribe progressive addition lenses for this child. 2-year follow-up, myopia is stable, and there's something that I want to pause here and tell you once again. Mental health issues. We see a larger increase in the prevalence of anxiety and stress, even among children for that matter, because the amount of stress that they had to go through for this age is really large. And what we also found is, in spasm of accommodation, You treat the spasm, but you don't leave them there because a large percentage of these children also develop myopia later. Okay, so let's say they have spasms, you do cycloplegia plus 0.5 plano, emetrope, whatever, everything is normal, but you keep following them up because almost 16% of these children develop true myopia at some point of time. So spasms are once again probably indicating also they develop progression in myopia. Okay, that's also important. Okay, the second case I showed you at the beginning. I asked you what test you will do for this 25-year-old gentleman. No change in prescription, but intermittent blurring. What would you do? Same near points, same test battery, but there's one more test I'll add here. What is it? Everything normal here. See, NPC is normal, NPA is normal, NEM is normal, cover test is normal, but the person has intermittent blurring. Facility.
Also,
Accommodation
we
facility.
can check for dry eye because dry eye can also cause blurring intermittent.
Very good. Yes, you do dry eyes, you do facility, and again treat the underlying binocular vision dysfunction. Vision therapy, heart chart, facility training can be given for such patients. So, myopes, adult myopes who have intermittent blurring of vision, make sure you do accommodative facility training. Okay, so that's really key. And just to put things in perspective, these are all where binocular vision is very important. Okay, so look at the last where esophoria, high AC by A, larger lag, intermittent exotropia. Children who have intermittent exotropia are also at a high risk for myopia progression. So they both go hand in hand. So whenever you see intermittent exotropia, again keep a close watch, do vision therapy to control intermittent XT because intermittent XT is a risk factor. They go like children progress more when they have intermittent XT. Okay, so that's what I want to tell you about myopia. Any questions at this point? Oli has a question. Yes, Oli, please.
Hopefully I have the right question.
There's nothing like right question, wrong question. Question is a question.
Ma'am, so you spoke about two diopter flippers.
Correct.
So just give little insight about what would be the ideal flipper for different age group. For the assessment, at least. Therapeutic can go from a low to high flippers.
Right.
So I think there is a common myth that okay, use only two diopter flipper for everybody. So please.
Yeah. There's nothing like use, of course, plus minus 2 is the standard numbers. There is something called amplitude scale facility where you look at the amplitudes and then you scale the amount of flippers. I didn't touch there because I'm just getting started like kindergarten and I tell too much that they're not going to come start BD only. But generally, this is the moral of the story. You put a plus minus 2, let's say. You put a plus 2 and then they say completely everything is blurred. They can't clear. You need to reduce it to plus minus 1.5. You can go up to plus minus 1 also. You need to document your baseline facility. The numbers I hold in the clinic generally are plus minus 1, plus minus 1.5 and plus minus 2. For therapy, you can go beyond plus minus 2 also. Okay? But these are the three numbers and depending on the near points of accommodation and then the accommodative status, you can choose which flippers you want to use to document the facility. You want to add anything else, Oli?
That's clarified. So it should not be a myth that we use two.
Yes, standard, yeah.
And then somebody is not able to do anything with that. Especially with the minus lens you put at 32 years old, the exact case you started in the first case.
Yeah.
And they will see patient is already having latent hypermetropia. If you are giving minus 2 on top of that, patient is not going to see anything. Then you feel there is no facility of accommodation at all for this patient. This is a wrong method of doing that.
Thank you so much. In fact, yes, and these we do come across sometimes to change it. Thank you. There was a nice cartoon made everybody wake up. So myopia control, too much of noise which is happening around. I think when we go back, even I'm scared to practice as a myopia control specialist. I have to do too much for my children. Thank you so much. Questions any? Or otherwise we'll move next.
Next, yeah, I'm going to torture you because I have a flight to catch. Okay, otherwise I would give break, ask Gayatri to come, but unfortunately I need to just push this off and then like post lunch go. But yeah, see the whole message as ma'am said, there's no need to, of course she was pretty humble and said I'm scared, but not to ignore BD. That's the whole idea. And when you prescribe even your minisclerals or generally leave myopia, you do any specialty contact lenses, the centration of contact lenses is also as important as centration of spectacles. Especially like post LASIK, I haven't touched it at all. Decentered flap. Binocular vision anomaly is getting exacerbated after LASIK surgery. Vertical deviations getting manifest after LASIK or any refractive procedure for that matter, with more refractive procedures right now coming into place. So I would strongly recommend that just keep this in mind. In fact, like, you know, when the ophthalmology team should be working in such a way that, you know, like I'm going to be doing a surgical procedure and all my patients undergo this minimum test battery just to see am I really, like, you know, at risk for exacerbating or decompensating any of these issues. Because it's fixable. You work on it before surgery. So we in fact do a lot of facility training before LASIK for many of these patients. So that post LASIK they're just happy, like they don't come back saying, you know, I have this intermittent blurring, everything is coming back to me, blah blah blah. Or if they have facility, we tell you are still at risk, you might have intermittent blurring, your refraction will be taken care, but you might have to continue with your therapy even after your refractive procedure. This then goes hand in hand, and you find small verticals, all of that, like you manage it. You don't miss it, and then it then shows up as something which is like unmanageable after the surgery. Yeah, the anomalous correspondence case that Sumit raised. So yes, that is the myopia part. Now the most interesting, you're all going to jump right now and answer a nice session, a segue to launch, which is prescribing guidelines. Okay, I mean I love
this is.
Yeah,
I think each one should have your notepads, and if your notepads are finished, we'll hand over more to you. And this is very important when to prescribe retinoscopy. I think all of us must be doing.
Yeah.
Autorefractors we are doing. Thank you so much, Rizwana. And one more comment about myopia control is, we find the myopia control glasses going in optical counters as just sale products. It's good that if we can educate our patients also that it's not over-the-counter product. And maybe we actually invited the major team like SLR and Hoya, if they could be here, we could have actually helped them understand that these are not over-the-counter products. Even you can talk to your patients if they are asking you. They sell at 12,000, you're selling at 15,000. There is a science. You charge your fees for it.
Yeah. So of course the same Miller Rubin's quote that fine arts. So these are, I love cartoons. Okay, so look at this. The parent telling the person that makes a child, you know, because in there you can manufacture, you know, I want a child with blue eyes and a fair skin, but also a child with glasses that are so cute with touch of astigmatism. Like that's how we start, and then of course the line sitting on you, like on the hunter-gatherer time. If you have 3D glasses, this would be a good time to put them on to see that literally I'm on top of your sorts. See, prescribing spectacles in children is really an art. And there are multiple guidelines that keeps evolving, and of course we have lots of ophthalmologists, pediatric ophthalmologists as well here. So I'm going to compile evidences from various professional bodies and associations, including the American Academy of Ophthalmology, the Clinical Practice Guidelines, the APOS. But of course, like I want to use cases to talk to you about how do we then manage when we see a patient with particular numbers. Okay. See, this is a paper that's published in Optometry and Vision Science. I love the paper. You're all here for this reason. If you see, what is the one thing that changes the prescription? You know what? It is the degree of expertise of the practitioner. So you are like, when I was starting to practice my pediatric optometry, I was like super apprehensive. Can I really give this, give this? If you see a senior ophthalms or optoms, they'll all be like, you know, I know what to do, and then they'll just go ahead and prescribe. This is not the right way or wrong way. This is through a survey they found that the expertise seems to be influencing the numbers, because some senior practitioners are like, I'm only going to do this way. That's how the survey results came out. But some people, the younger people are all like, I'm going to look at management, evidence base and this and that, you know. But what is most important is continuing education, and that's why we are all here right now to understand what is really, you know, what are the important factors? So what are the important factors in prescribing spectacles? First, working distance, understanding where this child is working at. Now that with gadgets, how many of us really measure Harman's working distance? Or rather, give something to the child or even the iPad, okay? Give the mobile phone, now just, see whatever you want to see and see where they are holding the reading material, okay? Because the visual demand actually tells you a lot about how you should then advise them. And there are lots of other factors. So just put things, generally children are special because visual demands are pretty dynamic. They are in the process of emmetropization. The visual cortex is still plastic, which means you can really treat amblyopia, and if you don't treat, then that also can hamper with the overall visual development and development of general milestones as such. Genetic and environmental factors with all of this myopia thing going on. Then spectacle correction, how many of us have looked at it as an instrument in the global development of the child? You think you're prescribing spectacles, but you're prescribing the most important thing to the child, that is then going to empower them, not just with visual development, but with the overall global development. So if you prescribe the right numbers, you're doing the right jobs. That's where your role is important, and the cognitive level of the child also. All of these are, screenshots to take and keep. It's available from these papers. These are risk factors for amblyopia. So when do you consider a child to be at risk for developing amblyopia? Look at this, 12 to 30 months. Any myopia, any hyperopia more than 4.5 diopters, child can develop amblyopia. Any astigmatism greater than 2 diopters, child can develop amblyopia. And then of course there's strabismus and media opacity, which remains the same. Any deviation more than 8% diopters, the child can be at risk for amblyopia. But look at hyperopia numbers, they reduce a little bit, half a diopter over the period of 1 year to 4 years. And myopia, it again reduces by half a diopter from 1 year to 2 years, and then by 4 years, any myopia more than -1.5, you start prescribing. Now through cases I will explain this, so don't worry. This is from the American Optometric Association. This is this is preferred practice from the pediatric, the American Academy of Ophthalmology, which again talks about some of these numbers.
So Rizwana, before we go, Harman's was one of the questions which they wanted to know.
Yeah.
How do we do the Harman's distance?
Yeah, so Harman's working distance is from your elbow to your middle knuckle, okay? The distance from you measure the distance from your elbow. So my elbow to the middle knuckle distance is not the same as yours, right? So that is basically the distance that you measure to find out where you would be comfortable or where your visual demands are not that intense when you keep a reading target. Because sometimes, let's say you measure this and this is 30, but then you are so used to reading it at 15, which means you are putting your eyes at increased visual demands, okay? So that's why you measure this distance to see what is a recommended distance or a range where the child can then read or hold their reading material or their iPad or whatever it is, okay? That's what's the Harman's distance. There's so much research once again that came after Harman's, and then everybody said that 25 to 35, 25 to 40 or 30 to 40 centimeters is the good range. But mostly if you see, all of us are so much used to holding it very close, and children of course right now, yeah. So coming back to this, these are all preferred practice patterns. So what does this mean is, when we ask an ophthalmologist, when do you want to prescribe to a child who is less than 1 year, they would tell you that, if I see hyperopia of greater than +6 in a child less than 1 year, that's when I would like to prescribe. This is the consensus, okay? Same thing, when the myopia is more than 5 is when I would like to prescribe. So these are all numbers that came from the preferred practice patterns or the consensus of ophthalmologists from across the globe who gave these numbers, which you will see in many ophthalmology practice as well. They'll have these numbers on their desk. But this is a paper that I would strongly recommend you to go and read, when to prescribe and not to prescribe, guidelines for prescribing spectacles in infants and children. So Susan Lee in this paper, she wrote a second version of the paper, but she asked you 6 questions, okay? First, whenever you see a child, the first question you need to ask, is this normal? Is this refractive error normal for this child? So you look at any chart that you want to use, you can stick to, and I'll tell you, these guidelines don't change much, okay? So you can take a chart, you can look at, is the refractive error normal? Second, will this emmetropize? Let's say a 2-year-old child, I see +5 hyperopia. Is it likely that these numbers will emmetropize? Third question, if I don't prescribe, will this interrupt this child's visual development? If I don't prescribe, I just leave it like that without prescribing, will this interrupt? The fourth question is, if I prescribe, do I expect an improvement in visual function, or can I do a trial to see if it then improves their visual status? Immediately putting that spectacle on, child feels so like, response. Then how much to prescribe? Then do I need to do other investigations? 6 questions. And I'll take you through the 6 questions with cases once again, okay? The first, just the case is there. Now you tell me how much you will prescribe. School going kid comes to you, not worn glasses, unaided visual acuity 680, cycloplegic refraction -2. How many of you will prescribe -2? Like the full cycloplegic refraction? Just raise your hands. Okay? You can raise it like that, like I don't have to think too much.
We're all in the same boat.
Yeah. How
I
many
mean, same all of us. Let's be getting clarity. Be sure.
Under pressure.
Okay.
सचमुच क्या करोगे?
Yeah.
Raise your hands. -2, how many?
Okay,
Rise
-2.
to? Many, let's say 25% would say -2.
How many of you want to undercorrect?
Okay, how many less than -2?
Okay. Okay.
Why we are not being subjected to the post-pediatric test in a 20-year-old child? Why only direct cycloplegic refraction?
Okay. I expected that question. So, there's no right or wrong answer. Of course, you should do your acceptance and you should prescribe a number where visual acuity is the best, plus diagram is also balanced. I'm making a statement here, diagram is balanced, not read better. Not read better, please. Because we are not talking about the undercorrection thought. I am not going to go into that school at all, undercorrection, because there are a lot of papers that talks about undercorrection is also a risk factor for myopia progression. But there is not much evidence for even that school, but I am trying to tell you, prescribe optimal correction, okay? Where you leave the child with diagram balanced. Now, look at this evidence. School age myopia, prescribe full correction. Prescribe full correction. What do you mean by that is that in myopes, when you do a cycloplegic refraction, that is the full correction. There is no need for you to undercorrect. When will you undercorrect? So those of you who raise their hands, when will you undercorrect is go back to the myopia talk that we just had. If you see a ESO, if you see a larger lag of accommodation, even then you don't undercorrect. You give the full correction for distance, but you introduce a myopia control option. You do your defocus lenses or you do your progressive addition lenses. Do you understand? Like, do you get the point where I'm going? You don't undercorrect. The reason is, yes.
I just have one doubt.
Yeah.
The vision is 618.
Right.
And for that, the amount of power is not high for us to give -2.
Correct.
That's the only thing I had.
Yeah. So you go to your logmar number of lines. If you look at that lines, number of lines, because you are just counting 4 lines from Snell, and if I am thinking,
Yes.
if you go to your logmar, there are 8 lines, and then you count, you can then equate this. This is where again we make this mistake of missing that 1 line, increments in logmar, for which for every increment you have 0.25. So 6.6 to 6.7.5, then 6.7.5 to 6.9.6, and then from there on. But yeah, the thing is, if you leave with minus, let's say 150 or 175, just 6.6 border, diachrome read better. Now there's a slight amount of blur and they're going to keep accommodating even with the spectacles on, right? And this relative peripheral hyperopic defocus. The blur is again a risk factor because it's going to add to the incremental increase in the axial length. So blur overall, you want to correct it optimally in such a way that, of course, now we are only talking about central focus. By prescribing -2, you're ensuring that the foveal reflexes, the foveal image is clear. Unless you measure peripheral refraction, you never know how much is peripheral hyperopic defocus. I've not even gone there yet, okay? But don't undercorrect. Just give optimal correction. Keep diachrome balanced as something like your easiest way to then prescribe, if that makes it clear. Of course, do your cover test.
Second adding information was logmar charts are also important when you're doing that, and we shouldn't be just doing Snellens.
Correct.
You are telling to take the cycloplegic refraction, do the full. Which cycloplegic refraction are you talking here?
I mean, of course, whatever that should be using, cyclopentolate is a standard, which is again what most studies use. I don't see studies using homide much. So, but again, there are some protocols, especially in India, where we do CTC, cyclopentolate, tropicamide, and again cyclopentolate. But if you look at studies, they use a C and a T, which is cyclopentolate and tropicamide. But yes, cyclopentolate is a standard, unless then there is seizures or any other contraindications where you then use homide. Yeah. And spasms, I am a strong proponent for atropine. 1% atropine eye ointment for 3 days and then the refraction on the 4th day. Okay, now tell me, I'm not going to read the story here, so that I'm going to make you read it. We spoke about binocular vision anomalies and myopia. We said intermittent exotropia. So I was waiting for this case. 8-year-old child comes to you and then has intermittent exotropia of about 30 prism diopters, and this is a cycloplegic refraction value. How many of you would go ahead and prescribe this fully? Okay, anybody would not want to prescribe it fully? Just raise your hands. Anybody wants to undercorrect in this case? Because even in the previous case you said full correction, so we are not going to undercorrect here. Over minus, okay. That again, we will take a call based on the, if at all like this poor control, or then I said CAC, which I'm not going to go. But look at this, there is this population based study of children with intermittent exotropia, you know. In this study, myopia was calculated to occur in more than 90% of children with intermittent exotropia. So 90% of people with intermittent exotropia also had myopia. So IXT and myopia go hand in hand, but management is full correction of myopia and astigmatism as the first step in intermittent XT. So any exo you see, don't worry, prescribe the full cycloplegic correction, do your PMT, don't break your head much. Should I cut the astigmatism by half, by 0.75, increase? Do your PMT and your JCC refining and everything. If this child prefers -3 at 170 where it's clear, prescribe that. Okay? But there is nothing, there is no rule like I can't do -3, this is going to cause visual disturbance, I'm not going to give any astigmatism more than -2. There is no such rule first of all. Children are pretty much adaptable to full correction of myopia and astigmatism. Adults, I would say, suppose you see a 30-year-old with all of a sudden 3 diopter cylinder, if you prescribe next day, they'll come and hand over the glasses back to you. Because facial distortion, adult visual system can't tolerate. Okay? But children can adapt, and because for children this is also an amblyogenic risk factor. So if you don't prescribe the astigmatism fully, you are also then not giving them an optimum visual quality. Okay? Okay. 6-year-old child, unaided vision. Take a note, 6'9", never used glasses, cover test ortho. Now this is the cycloplegic refraction and post-mydriatic test. Okay, 6-year-old orthophoria, visual acuity is 6'9". Okay, and I have given you the cycloplegic refraction and acceptance. How many of you will go ahead and prescribe this glasses? Okay, PMT +1. If the child accepts, you will prescribe it, right? There is nothing like, oh, I won't prescribe or anything like that. First time glasses. First time visual acuity is subnormal, 6'9", and that's when they came, and with the +1, visual acuity has improved. Do we really cut down anything further than this, or we go ahead? We go ahead, okay. See, once again I'm presenting this case because there are lots of myths around, will this child hemetropize any further? 6 years, there, you know, can I just remove the plus totally, only give the astigmatic correction and see? Or what is the minimum amount of hyperopia I prescribe? Okay, prescribe whatever the child accepts and are comfortable with. Now, the question that you need to ask in this particular case, the 6 questions. First, is the refractive error within the normal range for child's age? No. For 6 years, +2 is still above the normal range. Hemetropization has not happened effectively. Okay. Will this refractive error hemetropize? Unlikely. May change, but right now child needs a prescription. If you really look at the unaided visual acuity without the prescription, it's 6'9". So definitely the uncorrected refractive error has impacted visual acuity. Child needs correction. And with the spectacles, you see an improvement in visual acuity. Now, how much to prescribe? Partial, depending on the symptoms and improvements in visual acuity. Now, let's say this child is pre-verbal, not 8-year-old, not responding, like not 6-year-old, not responding. Now, how do you do? Look at this. Any amount of hyperopia greater than 2.5 diopters at 4 years. This number you should never forget. 2.5 diopters hyperopia from 4 years onwards is always a risk. They are least likely to hemetropize. They are most likely to develop strabismus. Even if they have an onset of strabismus, it's most likely to even complicate the visual development and everything. This 2.5 number definitely is like a good threshold. You can go ahead, cut 1 to 1.5 and prescribe that partial amounts of hyperopia because it helps with the child's visual development and it also improves the visual acuity. Okay? So this is something I wanted to tell you. Now once again, just take a screenshot and keep it because these are all guidelines. I'll take you through a little bit, another couple of cases and I'll come back to these guidelines again. Here, any hyperopia greater than 3.5, if you really look at developmental delays or strabismus, please give as much plus as possible. In developmental delay, delayed milestones and strabismus, full correction of hyperopia or maximum amount of hyperopic prescription is generally recommended. So I'm going to now take you through another case of like a little bit complications. As you see here, child who has a diagnosis of ROP, history is here, 4-year-old child. So you know like, okay, when you do refraction only, you are feeling very jittery, what am I going to get and everything. 28 weeks, of course all the birth history is there, I'm not going to go through. But this is the refraction, okay. 1 year, some hyperopia and astigmatism. So this is a case, I mean these are all cases that we've seen in the practice, right? So we did not prescribe. We said, okay, observe for now, 1 year is too early to prescribe. So we just documented. At 3 years, the astigmatism you see didn't change much. Hyperopia changed a little bit. Visual acuity was 612 with Leah symbols at 3 years. Okay? Is 612 normal for 3 years? Is 612 normal for 3 years of age? Huh? Yeah? Yes. Okay, so with Leah symbol, 612 is almost normal for a 3-year-old child. Okay, so once again, you should not threaten or you should not scare the patient by saying child has poor acuity. Don't give any such things. Now 4 years, if you see, nothing much has changed. Do you see? From 3 to 4, the values almost remain the same. So almost hematropization is not happening. It's just the refraction has halted. And what's happened to the visual acuity? It's reduced. Okay. So is this do we prescribe right now?
Yes.
Of course, yes. And even here at 3 years, actually speaking, we could have done a partial correction or prescribed astigmatism. But these are real cases where based on different consensus, an observation was done. But at 4 years, you see here visual acuity has started dropping. Now this is an age where, of course, if you ask those questions, this child definitely has amblyogenic risk factors when it comes to refraction. So if you see, if you look at guidelines, any astigmatism greater than 175, okay, is amblyogenic. So you should always keep this on your list for amblyopia and prescribe. So this is one chart where you can always keep going back and forth. For a 3-month-old child, if you see refraction between -2 to +2.5, you don't intervene. You see refraction between -2.5 to +3.5, you observe, but you can also do partial correction. If you see anything from -4 to +5, the upper limits, you will prescribe. So this is based on various studies, the confidence limits for prescribing corrections in different age groups beginning from 3 months of age. So this will tell you what is the risk of amblyopia. So if the child is within the inner 2 lines, you are safe. If they are in the middle 2 lines, the risk factor is sort of there, present. You observe and you start intervening. 100% if the refraction has crossed the middle line and if they've gone out, you prescribe. Now just to simplify it, let's say 5 years of age, 60 months. Any myopia, let's say any myopia you start prescribing, and any hyperopia more than +1.5, you really prescribe. Okay, so that is how you use these prescriptions. And just to summarize everything, in preschool, school myopia, please prescribe based on visual demands. Do not undercorrect myopia. School, again, full prescription in school age. Start introducing myopia control strategies. Astigmatism, anything above 1.5, start prescribing from pre-verbal to preschool. Anisometropia, very, very crucial. Anything above 1 diopter, child is at risk for amblyopia. Again, if you look at the anisometropic thresholds, for hyperopia, it's a very, very small number because any anisometropia more than 1, there is a risk for strabismus in hyperopia. Okay? In symmetrical hyperopia, let's say there is no anisometropia, any number greater than 4 diopter, the child is at 13 times at risk for amblyopia and strabismus. So the moment you see hyperopia value which is 3.5 or above, you should know that time to prescribe. There is no need to wait. If there is esotropia, developmental delay, Down syndrome, cerebral visual impairment, cerebral palsy, anything else, full prescription of hyperopia. Okay, full prescription of hyperopia and astigmatism in any of the developmental anomalies. There is no need to break your head much there. Go ahead and prescribe. Same thing with myopia. Okay, so this is all a quick summary of prescribing guidelines. But wherever an acceptance is possible, please do acceptance. Work towards prescribing an optimal correction with duochrome balanced. And then whenever there is a strabismus, do full correction. Okay. And I want to end with saying spectacle prescribing is an art and it requires interpretation of the child's refractive error and visual acuity. And as I told, this is not just visual development, this is global evaluation of the child. And the spectacle that you prescribe to the child is helping the child to read better, see better, and vision is then serving as a stimulus to the overall global development of the child. So what you are doing is not just a matter of prescribing glasses, you are actually doing a greater service to the child. Okay? So keep it very, very close to your heart, this whole art of prescribing spectacles. And I think it's a good time to do it.
Anyone has any questions?
Yeah.
In case of anisoconia, anisometropia, gross anisometropia, having 2 and 10 mild.
Okay.
How do you prescribe the glass, keeping in mind also the anisoconia part?
Right, so I would go with straight contact lenses.
The child is small.
Yeah, but still I know there are hard lenses that we can look at. But unilateral aphakia and all we've done just
the normal refractive
but then
errors.
we can still do spectacles if the hard lenses are not at all possible. If 2 and 10 is the thing, just have to work through dispensing the best.
Will glasses cause anisoconia image disparity?
Of course.
Then, and not the contact lens?
No.
No. Then what does the NAP say?
Right. No. So anisoconia is reduced with contact lenses. It's not eliminated with contact lenses. Because of the vertex distance being brought closer, you are reducing the amount of anisoconia. But you are talking about what is the age of this child?
Around 5, 6, amblyoptic age also.
Then I would go with contact lenses.
Okay, the NAP rule says that if you are using glasses, the glasses will not cause image disparity.
So that is about axial.
Yes. So if it is below 2 diopters,
Correct.
it will not cause it. And say if an axial, in those cases, how do you prescribe the glasses?
So in case of an axial, you straight away go ahead with your contact lenses because it works.
But that will cause an image problem because it's an axial one.
Okay. Now this is very theoretical. Whatever we are talking about
Yeah.
with anisoconia measurement is very theoretical. None of us do have an iconometry to actually measure what is causing what. But looking from the cosmetist perspective, plus also the compliance and everything, lenses have always been shown to provide, let's say, better visual fields, magnification differences that happens between the 2 eyes, and also binocularity wise, contact lenses are much better option compared to spectacles. And of course, anybody wants to know more about the course or the book, please feel free to reach out, and of course, as we told, all of the participants do get your discounts for the purchase of the book and the course.
I think we had a very exhaustive and wonderful session, and I think ma'am made everything navigate very easy these complex topics. So moving forward, we have a few guests, our guest of honors who have just recently joined us, very renowned ophthalmologists. So I would like Professor Monica Chaudhary ma'am and Dr. Anita Irving ma'am to kindly come on stage and honor our guests. So first of all, I would like to invite Dr. Devinder Sood, who is an very famous glaucoma surgeon and is heading the department of glaucoma at Indira Gandhi Eye Hospital. A big round of applause for him. Next, I would like to call Dr. Farooq Sharma ma'am from Max Hospital, who is heading the Department of Ophthalmology at Max. So, a little bit up there. Sir is currently working pioneering amblyopia and binocular vision management for 3D vision in Binox vision enhancement. He is the founder director of Binox, obtained his optometric and research training at George College of Management and Science, LV Prasad Eye Institute and Chitala University. He has a vast teaching experiences in the field of optometry and presenting his research work as of now along with his specialty clinical work. He is one of the pioneers in depth of vision therapy research for amblyopia and anti-suppression. So, please, I would please welcome sir with a big round of applause for the topic management of ideas and MCVI and anomalies in Binox vision therapy. Thank you.
A very good afternoon, all of you. It's my immense pleasure to be here and in front of all of you and discussing binocular vision related issues. And after that extensive talk on non-strabismic binocular vision disorders, I think my topic remains very, very limited. So I'm trying to focus on how we can do a little bit extra on managing intermittent strabismus in an orthoptic way. So we all know what intermittent exotropias are. It's a sensory motor anomaly. So we are talking about a sensory component as a motor component. This is just the only portion I want to highlight here, because the management is going to be based on what the sensory component will take care and the motor component, the strabismus surgeon is going to take care in this perspective. So if you look at the population that are affected, every one of us, in fact I will say most of us take birth with some amount of exophoria. Now as the binocular vision develops over a period of time, it slowly goes off. Now if there are any barriers to it, it tends to get affected and slowly develop as an intermittent exotropes. So by the age of 3 years and predominantly after 5 years, if you see some patient or child still possesses large exophoria, they are going to break into IXTs, and over a period of time they are going to decompensate and get into exotropia phase. And you saw the case Rizwan ma'am was discussing about getting into ERCs and all those cases. Now, what is bothering for us in intermittent XTs are the intervention that we do, whether surgical intervention or we're going to do something else, and that is going to determine by different factors. Now, what are the important factors you need to look at is what the component of exotropia you are looking at, especially whether it is the control, sensory control, or the motor deviation over a period of time, whether they have good stereopsis form or not. And please note that stereopsis for near has no relevance on a strabismus outcome in IXT. It is more of the distance stereopsis which is very, very critical to look for. And if they can control the squint or the deviation and not breaking the distance stereopsis or not getting decompensated, still the orthoptic way can give a good results. And only when it's breaking, then get into a surgical intervention to correct the motor deviation. Now, as we know, to get into any kind of treatment or management, a little bit of etiological factors which are very critical. So there are different theories. If it is intervention in nature, innervation in nature, you know that there are theories talks about that because of misinnervation or unequal innervation in two eyes, that IXT tends to happen. Mechanical is more related to the globe position or the orbit, how it is constructed. Position is what probably we will believe more and more, because as I just mentioned that by birth we tend to have exophorias, but over a period of time as the fusion stereopsis develops, it goes off. So that means more theories are coming up and supporting your fusional component. And refractive error with myopia, as you saw, 90% of IXTs would have myopia, as Dr. Rizwana also mentioned. So it is critical to know how the myopia is progressing in these kids, and you tend to get exotropia at over a period of time. Now, when we have this intermittent exotropes, is to find out how often they are squinting, what is the grade of their binocular vision, and the stereopsis, whether there are any abnormal head posture that are associated, even the academic performance of the kid, whether that is impacting apart from their psychosocial behavior, and then any unhappiness with the previous treatment and intermittent doubling of vision. So when they are getting into doubling of vision, then that means you know the amplitude of this convergence is not able to compensate over the amount of deviation they have, as we need a double of the deviation to prevent the double vision. So the management depends on which type of IXT you are taking care of. If it is divergence excess, you know that predominantly the near and distance deviation is differing, as in 10 diopter at least, more for distance. Pseudo divergence, when you first do assessment, you feel it is distance is more, but you do a patch test of 30 to 60 minutes, and then you redo the evaluation, you feel that it is coming out to be a pseudo divergence and comes more of a basic component, where basic exotropes or intermittent exotropes, where the distance and near is pretty similar or less than 10 diopter of difference, and pure converging insufficiency time, where you have more of near issues. Now, we are more focused, or we are more commonly known to the last component, is a converging insufficiency type, but never forget about the others, because those will play important role in managing the condition. And these are the different methods we do. You have alternate patching, as if you remember the first talk of the day, Pradeep sir mentioned that it is the pursuance of developing stereopsis, and please do not patch them and break the fusion, where there is a maximum need at that age of 5 years or 6 years of child, where there is a need of development, and if you patch them alternately, you are going to hamper the development of stereopsis. So though the patching or occlusion is being largely prescribed by clinician, it is one of the most deterrent in amblyopia and suppression management in IXTs. Surgical intervention in cases, as I mentioned, if it is purely motor component where there is a decompensated exotropias, then you need a surgical intervention, where the most common one is lateral rectus recession, and then there are recession and resection of the same eye, followed by some less cases of medial rectus resection. So these are the things done. But what we are focused here more of the binocular vision therapies, where you have different phases to do, and that comes because of these shortcomings of the previous or other modes, which are primarily the compliance with it. Even though if you do patching, it has a compliance. The results are unsatisfactory if you do patching, and then cosmetic is an issue because the problem that they have. And if you do pure surgical without taking care of the sensory component, then the recurrence are going to be very, very high. And typically within 1 year of operation, you tend to see they do get recurrence of the IXT. And if you do the second surgery, the problem comes with their dissociated deviations. You will get dissociation, horizontal deviation, and vertical sometimes as a surprise. So that becomes a more critical, I would say, to manage the binocular vision. Now these are the different phases in binocular vision therapies. Optimal correction is the key. So as again the guidelines already being discussed just now, a proper and a full refractive correction of myopia needs to be there, and most of 90% would have myopia, so that's why optimal correction is very, very adequate. Proper counseling about what you are going to do over a period of time, because it's not an overnight thing for IXT management. Probably protocol of 6 months or a year counseling is what is very, very crucial. As a phase 2, IXT is one of the components where there will be intermittent suppression to prevent the double vision. If somebody do not have intermittent suppression, then they will see doubling happening. Now, if you want to overcome that, you have to give anti-suppression component, anti-suppression therapies to bring back a binocular single vision. And then at the same time develop the flood fusion in a gradual way so that they do not have an intractable diplopia. The concern for any binocular vision therapies is not to get into phase of intractable diplopias. So if you transiently introduce the anti-suppression and fusion development, you are going to be beneficial and you will not going to get into any kind of intractable diplopia. Now once the phase 2 is over, then you get into developing that stereopsis. And again, stereopsis, though it is best developed at the age of 3 to 5 years, but nevertheless even in older age group, you can develop them, but younger you do better the outcome it is. And then once that is there, you work on the fusional versions which are more of junctions in nature. Now again, to hide any kind of squint and double vision, just to reiterate, the amount of deviation whatever patient has, motor deviation, you need to develop a double of that sensory component, which is the fusional amplitude, so that you can prevent that double vision and the manifestation of the squint. So this is a phase-wise manner where you can decide your own protocol, but typically what we advise in a binocular vision therapy is with Binox program. I have those, probably a couple of games to show, which I'll play during these sessions, I think, lunch break. So this is the protocol. What we follow is 8 weeks with the intensive therapy that you do, so that you break the suppression, you get their flat fusion developed, work on the stereopsis, and then start on 16 weeks of intermittent therapies, which will be once or twice in a week, so that you are maintaining their gain, whatever you have. And over a period of time, once you are confident enough that patient is holding it back, then you can probably call them every 3 months for a follow-up to check how patient is doing at this point of time. So the aim of the therapy is not only to work on the sensory component, but look for the home control, how the patient is managing at home, because that is the maximum time the parents will be observing the child. It's not about the clinician seeing for 15-20 minutes, where we tend to miss out a lot of components. So if you are asking the parents to at least train them how to do this NCS, Newcastle's observation score at home, whether the control is poor or like whether 50% of the time they look at the child and see the IXT is manifesting or it is less than that. So those kind of control, if you train the child, parents, then it becomes more successful outcome, because you can control that part of patient strabismus. And these are some cases, very typical case of this one of them spoke about IXT patient who has commonly you will get with some meridional component in terms of the amblyopia they do possess with. They have very poor control unless you have complete refractive correction and introduce binocular therapies. So the point you need to observe over here is the distance stereopsis though there is a 120 seconds of our near stereopsis, patient does not have any distance stereopsis, and that is where the surgery will come into place until unless you work on an early phase before the decompensate happens. So if we introduce a binocular approach, therapeutic approach, you can land up in getting excellent grade of stereopsis, not only for near, for distance as well. As again, the distance stereopsis work is critical for IXT management. The same patient improve the visual acuity and the good control over the deviation and good amount of stereopsis. So advantage over any other management, it is very simple way to manage your IXT patients. Compliance is very good because you are giving a gamified component of therapeutic approach. It can restore binocular vision to the highest level, and the development of stereopsis can happen for both near and distance. And you can, at the same point of time, work on their convergence amplitudes. You can gain control, good control of the exotropia. Having said that, the motor component you are not going to correct at any given point of time with any binocular therapies. It's the surgery is actually going to take care of that. All what you're doing is the sensory component, building up so much of sensory control over the motor deviation that it do not manifest at a given point of time. So that is what the aim of binocular therapy is in intermittent textiles. Just a brief of binocs that we have presents, though because of some industry presentation was there. We are available so patient can access this program across the globe. And just day before yesterday we got our patent which was applied in 2020. And the same process of how we develop binocular vision and how you can manage in a binocular way. Thank you for your time.
So any questions? Intermittent exotropias? I think it's a very common thing that we come across. And 40 prisms or 50 prisms and good fusion. Lot more could be done. We also handle one case of operation as compared to. Thank you. Any questions? And I know everybody is waiting for lunch.
What's the cost factor for the patient?
You can discuss cost factors.
Yeah, so we can discuss.
Some of the students are also here. Thank you. And a lot more. In fact, you have all your time to ask your questions. I know each one is looking at your.
Thank you so much, sir. Hello. Okay, now before the lunch, I would like to request Dr. Reena Sethi, who is the heading the ophthalmology department at Arunadai Eye Desert Hospital in Gurgaon, to please come on stage for a token of felicitation. Give a round of applause, everyone.
So we will now break for lunch. The lunch duration is going to be exactly 35 minutes because we are overshot on time. So post lunch, I'm sure you all enjoyed the first session of the day. Post lunch session is going to be equally interesting because we will be talking about amblyopia and lots of interesting case presentations and a lot of learning also there, and pediatric management and especially on amblyopia management by Gayatri. So please have a quick lunch and get back. In the meantime, when you get back earlier, we will be playing some video demonstrations of certain tests which Dr. Rizwana was mentioning in the morning. So please do have a look and enjoy your lunch.
Have the industry also is there, but we request that lunch and other as early as possible you can come back to the hall and watch it.